We do determine the BRAF status of every patient with advanced melanoma. Whether we start with BRAF targeted therapy or start with immunotherapy really depends upon how sick the patient is with melanoma. If the patient is very sick and has a large disease burden, we would start with targeted therapy because we can get a very fast response. But if patients are not in need of immediate treatment, then we would consider these new immunotherapy approaches. We would use ipilimumab, or we would enroll patients on a clinical trial with the PD-1 antibody, and then use targeted therapies for later in the course of a patient's disease. So it's critical that for every patient with advanced melanoma, we know their BRAF mutation status, determine that. If they have a mutation, then it's a question of what's the right sequence. If they don't have the mutation, then we move on to focusing on immunotherapy approaches. It's remarkable that we don't think about chemotherapy now in first or second line. We really think about chemotherapy for later in the course of the disease. So the data from this year's ASCO really enhances what we know about the impact of these new immunotherapies with PD-1 antibodies, with new approaches with IPI, making the treatments better, decreasing the side effects. So it truly is this remarkable time for patients with melanoma and a lot of hope.